Hello guys, welcome and welcome to Metier Academy, one of the leading academy in training nurses and nursing competitive exam as well as IELTS and CLEX and OET training. Hope everyone is doing well. So this video is the continuation of NORCET-9 video, that is NORCET-9 question paper, mains question paper we are discussing. Already part 1 video, it is streaming in YouTube channel. This is the part 2 video. So please watch the video till the end. Definitely it will be so much useful for you. And from the Metier side, for NORCET-10, we are giving the regular batches. See, 3 batches are available: 4 months course, 6 months course, 1 year course is available. Those who are willing to join as early as possible. Today is the last date to get admission. Only limited seats are there, so join as early as possible and get succeed in the first attempt. Okay guys, let's begin the question paper discussion of NORCET-9 mains question paper. So 21st question we are discussing. A patient has congestive heart failure and develop hyponatremia. What will be the appropriate management? See, 2 key points they already given here. The first one is congestive heart failure. So congestive heart failure means immediately what should come into your mind? Fluid overload. Fluid overload will be there in congestive heart failure. Because of the fluid overload, the patient will be having dilutional hyponatremia. Here just they have mentioned hyponatremia, but the exact word is dilutional hyponatremia will be there because of congestive heart failure, because of fluid overload. Okay, so how to manage this situation? 4 options they have given here: saline infusion, loop diuretic, fluid restriction, and sodium diet. So here the right answer is option C, that is fluid restriction. Why I have selected fluid restriction? Here you can see very clearly saline infusion. Already they have having fluid overload. If you are infusing the saline, what will happen? Again, the fluid overload is going to take place. It will worsen the congestive heart failure. And the last one, sodium diet. See, already the patient, even though the patient is having hyponatremia, sodium diet, high sodium diet worsens the fluid retention, and again it will increase the congestive heart failure. So you should not give the sodium diet also. Whenever the sodium retain inside the body, it will retain along with the water and it will cause further increase in the fluid overload and it will cause congestive heart failure, right? Fine. So what is the left option? Leftover option is only 2, that is loop diuretic and fluid restriction. These 2 things are totally related to congestive heart failure only. So among these 2, only one is the answer. See, obviously option B, loop diuretic, we can give loop diuretic to the patient. It will reduce the fluid overload, but certainly it will not act on, or it will not correct the hyponatremia. Okay, it will correct the fluid overload, but it will not correct the hyponatremia. So loop diuretic along with the fluid restriction, it will correct the dilutional hyponatremia also. You can see here fluid restriction is the best choice, decrease the water overload and correct the dilutional hyponatremia. Okay, so fluid restriction and loop diuretic both are together we have to give to the patient, but if you are taking the priority, first thing is fluid restriction. Followed by that, loop diuretic we supposed to give. That's why I have selected option C, fluid restriction, as the correct one. Okay, the next one, a patient diagnosed with diabetes insipidus, very interesting question, repeatedly asked question. Diabetes insipidus is treated on vasopressin. Vasopressin is also what? Antidiuretic hormone. It is also called as antidiuretic hormone. See, vasopressin, desmopressin, and antidiuretic hormone, all 3 are same. Vasopressin or desmopressin is means available commercially in the pharmacy. Fine. So what is diabetes insipidus and what is vasopressin? These are all the 2 key points in this question. If you know about these 2 things, easily you can answer this question. Okay, fine. What is diabetes insipidus? Lack of antidiuretic hormone. That is called as diabetes insipidus. Whenever there is a lack of antidiuretic hormone, what will happen? Excess urine output will be there. Polyuria will be there. Okay, so in order to control the polyuria, the drug of choice is vasopressin. It is also called as desmopressin. This is nothing but it is a commercially available antidiuretic hormone. In diabetes insipidus, lack of ADH, so we are giving the ADH from outside. That is called as vasopressin. So whenever you are giving the vasopressin, the urine, the polyuria is going to get controlled. What is going to get controlled? The polyuria is going to get controlled. Once the polyuria is controlled, automatically the urine output is going to get reduced. Okay, so diabetes insipidus patient who is taking vasopressin drug, the urine output is going to get reduced. Always remember, whenever the urine output is reduced, the patient will be having increase in the urine concentration. Urine output reduced means the concentration in the urine will increase. It is increased. This is the default scenario. Okay. So whenever the urine concentration is increased, automatically the urine specific gravity will increase. Urine osmolality will increase. Urine osmolarity will increase. Everything will increase. Whenever the urine volume is reduced, osmolarity, urine specific gravity, concentration, everything will increase. Okay, fine. So if you are having this concept, definitely you will go to the option A, that is urine specific gravity is 1.050, and also normal value is important. What is the normal urine specific gravity? 1.0102 to 1.030. 1.010 to 1.030 is the normal value of the urine specific gravity. But in this situation, the concentration of urine is going to get increased because of the drug vasopressin. So that's why here the urine specific gravity is high, abnormally high, then normal. Okay, fine. So on the whole, the right answer is option A, that is urine specific gravity is 1.050. Clear, guys? Fine. Yep. 23rd question. A patient is diagnosed with COPD, chronic obstructive pulmonary disease, and ABG, respiratory acidosis is there. Okay. This is also a repeated question. What is the appropriate nursing action? As you all know, in COPD, the first key point should come into your mind is barrel-shaped chest, and also the carbon dioxide, it is going to retain inside the alveoli. Okay, so whenever the carbon dioxide is retained inside the alveoli, because of the disease condition like COPD, automatically it will cause what? Respiratory acidosis. So here we need to treat the respiratory acidosis. How? By means of excreting the retained carbon dioxide. How you will excrete the retained carbon dioxide? By means of using a technique called as BiPAP, bi-level positive airway pressure. Okay, so you can see the other options. Give diuretics. It is not at all related to respiratory acidosis and COPD. It is related to hypertension. It is related to congestive heart failure. Right? Fine. So giving diuretics is not at all related here. The next one is set 10 liters per minute of oxygen administration. What that? Set 10 liters per minute of oxygen administration. Whether we need to give 10 liters of oxygen for COPD patients, we cannot give 10 liters of oxygen for COPD patients. See, it is a big pathology. The normally two types of drives are present in the respiration. The first one is hypercapnic drive. Second one is hypoxic drive. Hypercapnic drive and hypoxic drive. Whenever the partial pressure of carbon dioxide is increased, the central chemoreceptor, listen carefully guys, central chemoreceptors which is present in the medulla oblongata, it will get activated and it will stimulate the respiration and maintain the normal respiration. Okay, this is called as hypercapnic drive. Whenever carbon dioxide level is increased in the blood, central chemoreceptors which is present in the medulla will get activated and it will stimulate the respiration and maintain the normal respiration. You know that normal respiration is 12 to 16, right? Fine. On the other hand, suppose the patient with COPD, excess amount of retention of carbon dioxide will be there. In this situation, the central chemoreceptor which is present in the medulla oblongata, it will become resistance. It will become desensitization. It will not do its work. In a simple words, we can say like that. It will not do its work. At that time, there is secondary drive is there. The primary drive is central chemoreceptor and medulla oblongata. That is the one who is maintaining the respiration. That is called as hypercapnic drive. In COPD patient, hypercapnic drive will not work. So secondary one more drive is there. That is called as what? Hypoxic drive. What is that? Hypoxic drive. See, when this hypoxic drive will work, whenever the oxygen level is decreased. Oxygen level is decreased, this hypoxic drive, it will get activated and maintain the respiration. Understand guys? Fine. So on the whole, what I want to say is for a COPD patient, the maximum or the normal amount of oxygen delivery should be only 1 to 2 liters per minute. If you are increasing the oxygen, the second drive will also not work. Already the first drive, hypercapnic drive, is not at all working because of excess amount of carbon dioxide. And the second drive, when it will work? Whenever there is a low partial pressure of oxygen. But if you are giving more oxygen, what will happen? That low PO2, low partial pressure of oxygen, it will not be there. So the second drive will also not work. Okay, if it is confusing, just check in the Google, that is what is hypercapnic drive and what is hypoxic drive, so that you will get better clarity along with my explanation. Okay guys, fine. So setting 10 liters per minute of oxygen for a COPD patient is not at all a right one. Okay, so 1 to 2 liters is enough. So giving diuretic also we can eliminate 10 liters of oxygen per minute, also we can eliminate. Administer sodium bicarb. Why we need to administer sodium bicarb? The patient is not at all suffering from metabolic acidosis. The patient is suffering from respiratory acidosis. So eliminate this option also. At last, what is there? Option A, that is provide BiPAP, bi-level positive airway pressure. It is meant for excreting the carbon dioxide. Okay, fine. Once the carbon dioxide is excreted, the carbonic acid formation will not be there, as respiratory acidosis will not be there. Okay, fine. So question number 24, the normal number of breath given in a patient with advanced airway. Underline the key point, advanced airway during CPR in a minute is. In a minute is advanced airway during CPR in a minute. This is the key point. Okay, 4 options they have given here. See, according to American Heart Association guidelines, 2 things are there. The first one, no advanced airway. Advanced airway is nothing but inserting the endotracheal tube or a supraglottic airway, right? And then along with inserting ET tube, you are doing the CPR procedure. All those things are coming under advanced airway. Without inserting the ET tube or without inserting the supraglottic catheter airway, you are just doing the basic CPR, that is coming under what? No advanced airway. See, you can see here, AHA guidelines, basic CPR, no advanced airway. You doesn't introduce anything in the mouth like ET tube or supraglottic airway. Just you have to go with a 30 compression and 2 breath ratio. But this is not at all related to this question. The one which is related to this question is in advanced airway. You can see advanced airway, ET tube and supraglottic airway has to be inserted. Okay, fine. So in this advanced airway, 2 things you're supposed to note after inserting the ET tube. The first one is the chest compression should be continuous 100 to 120 per minute. 100 to 120 chest compression per minute. The first point. Second point, give 1 breath in every 6 seconds. Give 1 breath in every 6 seconds. It means totally you will be giving 10 breath per minute. So this is related to the question. So how many breath you will give in the advanced airway? 10 breath. How many? 10 breath per minute you're supposed to give in the advanced airway during CPR. Okay. If they're asking compression, 100 to 120 compression per minute. If they're asking breath, 10 breath per minute. Okay. So that's why we have selected option A. 25th question. Which of the following is the wrong statement in providing calcium gluconate administration? See, 2 times you will be giving the calcium gluconate injection. The first one is whenever the patient is suffering from hyperkalemia, in order to protect the heart, you will be giving the calcium gluconate. Second one, if the patient is going for hypocalcemia, positive for Chaustick sign, that time you will be giving the calcium gluconate. So how you will be giving the calcium gluconate? Whether we have to give very fast or slow or through intraosseous, through the bone we can give. So this is the question and answer options. So here the right answer is, it is a wrong statement except question. So here the right answer is option A, that is fast IV flush should not be done. Fast IV push should not be done while giving the calcium gluconate. Clear with the concept, guys? Yes, always when you are giving calcium gluconate, the cardiac monitor should be there. Slowly for 1 to 2 minutes you have to slowly push the IV calcium gluconate. And if the veins are not at all possible to insert in the vein, then the second option is intraosseous, in the bones. Okay, all the things I have given in the rationale also. Just pause the video and read it out. 26th question, it is a calculation question. Please look into that very carefully. The prescribed dose is 3 microgram per minute. 3 microgram per minute is the prescribed doctor order. Available dose is 4 mg. It is present in 4 mg in 1000 ml D5. Flow rate ml per hour. They are asking the flow rate ml per hour. Okay. So if you are getting this type of question, if they are asking in microgram and available dose is present in the mg, that is milligram. So what you supposed to do? See, 3 steps you have to follow, guys. Please listen carefully. Doctor order is in microgram. Available dose is in milligram, mg. So first convert the mg into microgram. First convert the mg into microgram. How to convert? See this mg, you can see here, convert available drug to microgram. So 4 mg, take this 4 mg, okay. So 4 mg is equal to how much microgram? 4000 microgram. So 4000 microgram in 1000 ml. 4000 microgram in 1000 ml. So 4000 divided by 1000, it is equal to 4 microgram per ml. Okay, very simple calculation, guys. Convert the 4 mg into microgram. How to convert? You can see here, step by step I have solved and I have given to you. 4 mg is equal to 4000 microgram, and this 4000 microgram is present in 1000 ml. So just divide it and you will be getting the answer 4 microgram per ml. So we got one answer, 4 microgram per ml. So we have converted mg into microgram. And next one, find required ml per minute. How to find the required ml per minute? See, here we are going to get divide. Divide the prescribed dosage, that is 3 microgram, and the dosage we got in hand, that is 4 micrograms. So 3 divided by 4 is equal to 0.75, and at last they are asking the flow rate ml per minute. So just calculate this value into 60. 0.75 into 60, you will be getting what? 45 ml per hour. So step by step, once again I will repeat. First convert the mg into microgram and then divide the prescribed dosage by available dosage, and the value whatever you are getting, just multiply with 60 and then you will be getting the answer, that is 45 ml per hour. So 45 ml per hour is the right answer here. Okay. The next one, while caring for a patient in ICU, nurse noticed the dislodgement of the chest tube. What is the priority nursing intervention? It is many times asked in the exam. Dislodgement of the chest tube means the chest tube which is present in between the intercostal space came out. Okay, so that is what dislodgement. In this situation, the first and foremost management is provide a occlusive bandage. What does it mean by occlusive bandage? See, the dislodgement area, it is prone for entry of the environmental air inside the pleural space. So what we are supposed to do, we need to cover the open area. Okay, so how to cover? By means of using the petroleum gas. Use the petroleum gas and seal the opening area. Okay, so that the tension pneumothorax will be prevented. You understand the concept? Whenever there is a dislodgement, take a occlusive petroleum gas and then stick it over the open area so that the tension pneumothorax will be prevented. Okay. Now, never ever try to clamp the tubing. That is the second option. If you are clamping the tubing, again the tension pneumothorax will increase. And dip the end of the tube in NS bottle. When we will dip, the test tube dislodgement is not there, but the test tube which is connected with the drainage bag is disconnected. Test tube connected with the drainage bag is disconnected means that time we can insert in the normal saline bottle. But here, what is the scenario? The chest tube is disconnected. In that situation, we have to cover it tightly. Okay, so here the right answer is option A. The next question is 28th question. A central line insert in the right subclavian vein. After insertion, patient suddenly develop dyspnea and decrease in the blood sounds. Repeatedly asked question again, guys. 4 options they have given here: air embolism, pneumothorax, infarction. So please remember that whenever the subclavian vein, through the subclavian vein, the central line is inserted, there is a chance for pneumothorax. Because the tip of the pleura, the tip of the lungs, which is covered by the pleura, it is just next to the subclavian vein. So while you are inserting the catheter, there is a chance for puncturing the pleura of the lungs. If the pleura is got punctured, so there is a chance for getting the air entry. So that time what will happen? Pneumothorax will take place. So whenever the patient is going for pneumothorax, the classical sign is decreasing in the breath sound. Please underline the word decreasing in the breath sounds. Okay, fine. So subclavian vein, this key point is there. Immediately you have to check for what? Decreased breath sound. If that word is also there, immediately you have to go for what? Pneumothorax. Okay, fine. The next question. During suctioning, the nurse noticed the patient's saturation level decreased from 94 to 88. What is the initial action? Very simple question, guys. If the saturation is dropping during suctioning, stop the suctioning. That's it. Okay, no need to think twice. Stop the suctioning. Okay, so here the right answer is going to be what? Option A, that is stop the suctioning. The next one, after suctioning, patient develops new wheezing sound. Underline the key point. After suctioning, new wheezing sounds and copious secretion is there. Okay, so this is the question, and three options they have given here: bronchospasm, laryngospasm, laryngeal injury, alveolar collapse. Like that, three options are there, and here the right answer is bronchospasm and laryngospasm. Why I have selected this answer? While you are doing the suctioning, if you are damaging, the technique is not correctly followed, if you are damaged the bronchi, that time the bronchi will get irritated and contraction of the bronchi will take place. It leads to new wheezing sounds along with the secretions. Okay, so it leads to bronchospasm and laryngospasm. Okay, guys. See, laryngeal nerve injury, immediately after doing the suctioning, laryngeal nerve injury will not be there. See, continuously if there is a damage to the laryngeal nerve, that time only laryngeal nerve injury will take place, not immediately after doing one suctioning. Okay, and alveolar collapse is totally, the suction tip doesn't going to enter inside the alveoli. It will go up to the bronchi only. So you can eliminate option C. The leftover option is bronchospasm and laryngospasm. The next one, question number 31. An inhalation drug, 2 puffs delivered in every 6th hour. Total 200 puff is the dosage available. Complete drug inhale in how many days? See, there is a puff inhalation drug. The capacity or the available dose of one puff is 200. 200 times you can do the puffing, 200 times. In 6 hours, 2 puff they are taking. The patient is taking 2 puff in 6 hours. So, in 6 hours, 2 puff means in 1 day, how many puff? 1 day, how many puff will be there? For calculating that, 24 divided by 6. 1 day is equal to 24 hours, right? So, just divide the 24 by 6. You will be getting 4 as an answer. So take that 4. So how many puffs they are using for single time? 2 puffs. So 4 into 2, it is equal to 8 puffs they are doing. 8 puffs. Per day, 8 puffs. Okay. And total available dosage how much? 200. So 200 divided by 8, it is equal to 25 days. So 200 puff dosage will come for how many days? 25 days. So here the right answer is going to be what? 25. Okay, the next one. What is the diagnosis of the patient in the given picture? So here they are given you one picture, and here you can see jugular vein distension. Jugular vein distension. This is the jugular vein, and there is a dilatation in the jugular vein. When the jugular vein distension will take place? Whenever there is a fluid overload. Whenever there is fluid overload. So directly we can go for the answer. That is hypervolemia is the right answer for this question. Okay, guys. And next one. What is the expected action for the patient with the following ECG finding? See, just understand the concept here. The QRS, 2R interval. This is one QRS complex. This is second QRS complex. The interval between these two QRS is wide. And this QRS complex is also narrow. QRS complex is narrow. And between this, the space between the two QRS complex is wide. Usually in between 2R interval, 4 boxes will be there. But here you can see it is more than 8 or 9 boxes. Right? And if you see, this is all about QRS complex. And if you see the P wave, the gap between the P wave and QRS complex is also huge. And this QRX complex and P wave, it is not at all related with each other. You can see here P wave, there is a gap, and QRS complex. Again here 1, 2 P wave, again QRS complex. 1, 2, 3 P wave, and again QRS complex. See, it shows that the P waves is working separately and QRS complex is working separately. In which scenario the P wave, that is P wave denotes what? Atrium contraction. QRS denotes what? Ventricular contraction. In which time these two things will work separately. If these two things are independently working, it is called as what? Third degree heart block. Guys, first degree heart block means only the PR interval will be prolonged. That is more than 20 seconds. Okay, in first degree heart block, only the PR interval will be prolonged. In second degree heart block, it is further classified into Mobitz 1 and Mobitz 2. Some P waves will not follow the QRS complex. This is the key point. Okay, some P waves will not follow the QRS complex, that is second degree heart block. In third degree heart block, atrium will work separately, ventricle will work separately. You can see here, atrium is working separately and ventricle is working separately. Okay, so in this type of scenario, ECG waves are present means we need to give artificial pacing, like transcutaneous pacing. Okay, see, thrombolysis, what is the use of giving thrombolysis? There is no myocardial infarction at all. So no need to give the thrombolysis. Oxygen administration, we have to give oxygen administration, but it is not a immediate management. Injection morphine, not used in AV block. We cannot use the injection morphine in AV block. It worsened the condition. So the leftover option is transcutaneous pacing. It is the one which is used in the heart block in order to maintain the proper SA node, AV node conduction. Okay, so here the right answer is option A. 34th question, a patient is getting NTG via infusion pump. Again, repeatedly asked question, NTG, nitroglycerin, through the infusion pump they are giving. What is the expected side effect in this patient? Three options, headache, heartburns, bloating sensation. See guys, very simple question. NTG, it will cause blood vessel dilatation. In brain also, cerebral blood vessel dilatation will be there. So because of the cerebral blood vessel dilatation, patient will be having severe headache after NTG infusion. So it will directly take you to the option A. Okay. Next one. Again, direct question. What is the flow of oxygen in ambu bag during resuscitation? Flow of ambu bag during resuscitation. You know ambu bag, right? So while giving CPR, we can use the ambu bag. So while you are compressing, how much liters per minute it will deliver to the patient? Per minute, how much liters of air or oxygen will deliver to the patient? This is the question. This is the standard question, and here the right answer is what? Option B. That is, in a minute, if you are giving oxygen with ambu bag, 15 liters per minute of oxygen is going to deliver to the patient. 15 liters per minute of oxygen is going to deliver to the patient by using the ambu bag per minute. Next question. While giving piptas and gentamicin, very important practical based question. Piptas and gentamicin both are antibiotics that want to know that both drug can be given. Okay, the question is both drug can be given together. For example, first you have given piptas, followed by piptas, whether we can give the gentamicin immediately? No, we cannot give the piptas and gentamicin in the same IV line. If there is only one line is present means at least 30 minutes gap should be there. How much gap should be there? 30 minutes gap should be there. Okay, so that is what they have mentioned here. For this question, 30 minutes gap should be maintained in between piptas and gentamicin. If you are giving piptas and gentamicin in a single light again and again, immediately the gentamicin action will not be there. Gentamicin action will not be there. Okay, so here the right answer is option B. Next one, question number 37. A nurse caring for a patient on ECMO, extracorporeal membrane oxygenation. So ECMO and suddenly get desaturation, but the vitals are stable. Two key points. Patient is on ECMO, desaturation is taking place. First key point, but the vitals are stable. In this scenario, immediately you have to think about what? The machine is working properly, but the circuit from the machine, there is some problem. That's why desaturation is taking place. So you have to check for the circuit. In the circuit, there might be a kinking, bending, clot formation, something might be there. Okay, that's why adequate oxygen is not delivering or adequate blood flow is not reaching back to the patient. Okay, so in this situation, you have to check for what? Circuits. Okay, so here the right answer is option B for Question number 37. Question number 38. The patient came with the complaint of headache, dilated pupil and tachycardia. Dilated pupil, headache, tachycardia is associated with what type of pain? 4 type of pain they have mentioned here: acute, visceral, neuropathic, chronic pain. And for this one, the right answer is option A, that is acute pain. Why acute pain? See, headache, dilated pupil, tachycardia, these are all the classical sign of acute pain. And other than that, visceral pain is there. See, visceral pain means what? The pain of the internal organs. It is usually deep, poorly localized. Only in this area the pain is there. This area the pain is there. You cannot localize the pain because this pain is from the internal organ. It will be generalized. Okay, so you can remove that. Neuropathic pain, it will be tingling or burning, pricking pain will be there. That is neuropathic pain, commonly seen in diabetic patients. And last video also I have said about gabapentin, pregabalin tablets, anti-epileptic tablets for neuropathic pain. And chronic pain, long-lasting and often dull. It is not acute, not severe, no tachycardia will be there. So if tachycardia, pupillary dilatation and severe headache, these type of symptoms are there, means you have to think about what acute pain, that is option D. And question number 39, image-based question. You can see the patient is lying in the prone position and there is a needle inserted in the epidural space and they are giving anesthesia. So it is coming under what? Epidural catheter insertion. Okay. The last one, a patient having a fresh GI bleeding. Fresh GI bleeding or upper GI bleeding. So this kind of words are present means the patient will be having what? Hematochezia. Fresh GI bleeding usually seen in the upper GI bleeding. The patient will be having vomiting, hematemesis. Okay, so fresh bleeding is present in the upper GI means it is called as hematochezia. Okay, there is small correction. See, use hematochezia, it is not from the upper GI bleeding. Hematochezia, it is from the lower GI bleeding, guys. Small correction. Okay. So hematochezia means fresh bleeding because of some problem in the lower GI. For example, you can take hemorrhoid. Hemorrhoid, there will be a fresh GI bleeding. Hemorrhoid, it is present in the lower GI. Right. So fresh bleeding because of hemorrhoid from the lower GI, it is called as what? Hematochezia. Second scenario, if there is a upper GI bleeding and the bleeding, it is seen in the stool, that is black and tarry color will be there. If the black and tarry color stool is present means that is called as melena. That is called as what? Melena, commonly seen in the upper GI bleeding. So upper GI bleeding, black and tarry stool called as melena, lower GI bleeding, fresh bright red color stool because of hematochezia. And anorectal malformation, it is a congenital defect not at all related to the fresh gastrointestinal bleeding. Clear, guys? Okay. So hope everyone understood the concept. Rest of the questions soon we will be discussing. If you have any doubts anywhere in these questions, you can drop your message in the comment section. And once again, I'm repeating for NORCET-10 from Metier side, either in the Delhi branch, in Delhi Saket branch, the new batch is going to start for NORCET-10. Those who are willing to join, please join as early as possible because limited seats are available. Same in Puducherry. We are starting with the NORCET-10 new batch. So if you want to join and want to clear the exams in the first attempt, please join and clear the exams as early as possible. Thank you very much, guys.